Bandana ji, you can start.
Hello, everyone, and welcome to this very special webinar today. As you all know, that this November is Lung Cancer Awareness Month, and um, for this Awareness Month, on behalf of Lung Connect India Foundation, we've been conducting webinars, and today is the last webinar in the series of 3. And today, I think the webinar that we are hosting is a very sensitive one, but a very important webinar. So my name is Vandana Mahajan, and I'm very honored to be a moderator today. Thank you for joining us for this very vital conversation on intimacy reimagined, finding joy and closeness beyond cancer. As you all know, cancer affects more than just the body. It can change identities. It can, affect intimacy issues. It can affect relationships both positively and negatively, and the ways we connect with those we love. And yet, sexual health is still one of the most underdiscussed areas of cancer care. So, our goal today is to shine a light on sexual health challenges during and after cancer, share guidance, strategies, and resources, and create a safe and respectful space for an honest dialogue. Just a few housekeeping notes so that all of us are on the same page. This webinar is being live streamed on Lung Connect's YouTube channel, and it'll be there for future references. We know this is a very sensitive topic, so if any one of you needs to take a break, please, self-care is very, very important. Now, starting this webinar, I'm going to take this privilege of introducing our panelists. Our first panelist is a very special woman. She wears multiple hats, Rasika Bumbatkar. She is a public health researcher at Oxford, UK. She's also living with stage 3 non-small cell lung cancer and is a champion of patient advocacy. Thank you for being here, Rasika. It's an honor to host you, and hats off to your courage and your grace. Thank you for being here. Our next panelist is Mrs. Rachna Vijan. She has a lived experience of breast cancer and is a champion for patient advocacy. Thank you, Rachna ji, for your courage and grace. I take this honor and a privilege to introduce all of you to Miss Lauren Pretorius. Lauren is a woman who dons multiple hats. She's a health advocate, a social entrepreneur, and a health strategist with 2 decades of leadership experience in cancer advocacy and health policy influence. She is the CEO and co-founder of Campaigning for Cancer, a patient advocacy organization in South Africa. Thank you, Lauren. Your presence is going to give us an international perspective to this very, very important subject. And our next panelist is Dr. Nandini Menon. She is a very passionate and dedicated medical oncologist who believes that all patients should have equitable access to resources. She works at one of the busiest medical oncology centers in the country, Tata Memorial Cancer Hospital at Mumbai. Thank you, Dr. Nandini, for being here. And we are waiting for our final panelist, and I'll introduce him when he joins. So I'm going to, narrate a small personal experience.
Dr. Akhil has also joined.
Okay, yeah. Good evening, Dr. Akhil.
Good evening. Good evening.
Good evening. Thank you for being here. Dr. Akhil is a medical oncologist whose heart belongs with his patients. He's a champion of patient advocacy and believes patient voices should be amplified and highlighted. He is a professor of medical oncology at, again, one of the busiest hospitals in the country, Mahamana Pandit Madan Mohan Malviya Cancer Center, Varanasi. Thank you, Dr. Akhil, for being here. My personal experience, I've spent a lot of time at Tata Memorial Cancer Hospital as a volunteer counselor. And this is from my personal interaction with the patients. I have done a lot, very closely involved with the post-op counseling sessions of breast cancer patient. And while one of the sessions was going on, a woman in her early 50s walked up to me and said, "I really don't care whether I have cancer or not. Tell me, can I be intimate with my husband?" This woman came from rural India. And in a rural setup, the intimacy between a couple really matters. So imagine the fear that was playing on her mind. If her husband thought that she wasn't fit to continue intimacy with, he would have left her. My second, second experience that I want to share with you, there was a young man in his early 30s. He passed because of non-small cell lung cancer. And while he was at end of life and struggling, he was in West Bengal. He gave me a call and he said in Hindi, he said, I want to ask you something, Vandana ma'am. I said, anything that you want to ask. And he said, I am unable to do it with my wife. And even while he was dying, this was what was bothering him. Unfortunately, this wasn't discussed. He did not have the answers to it. And as a counselor trained in sexual counseling, I was able to give a bit of direction to that, to the couple. So why is this silence around intimacy, sexual intimacy, sex, when somebody is diagnosed with cancer? I would say sexuality is often the conversation that never happens. So let's break this this taboo around sexuality and let's have an honest and open conversation. My question to each one of the panelists here is, why do you think sexuality remains such a difficult topic in cancer care? Rasika, let's start with you.
Well, as you very rightly said, Vandanaji, that I think it takes at least one of the sides to open up and talk about it. But I think, at least in Indian setting, neither the patient nor the doctor are comfortable talking about it. And being a patient, I would put the burden on the clinician's shoulder more, because as a patient, we are in this situation for the very first time, and we have 1,000 questions in our mind, out of which sexuality maybe for some doesn't become a priority, but it still is a question. And I think that's where a clinician should take that initiative to at least create that space where someone can talk about it. And yeah, I think that's the reason why it is still not being discussed in an OPD setting or anywhere else.
Thank you, Rasika. Lauren, from your experience, what would you, Lauren, are you there?
I am.
Yeah, okay. Why do you think sexuality remains such a difficult topic in cancer care?
I think there's a few reasons, and Rishka mentioned it, that there's that societal uncomfortable feeling when talking about sexuality just in general. So we're looking at that. And I think that there's also, we haven't created a role play or a role within the multidisciplinary team of a doctor and all the people that help treat that patient. We haven't created a role for that specific thing. And I think it's also a little bit of stigma when it comes like, well, you're sick. Why would that be? That should be the last thing on your mind. You're fighting cancer. People often think that people living with cancer, and sometimes it can be, but they see that sick person, linked up to an IV with no hair, and that's their idea of a cancer patient, and that's not what a cancer patient is today. Also, age. The patients are being diagnosed later, and I think that's also, diagnosed earlier, younger, and so it's one of the things that needs to be talked about because of, things like family planning and that. So it's something that's ingratiating itself into the discussion. But I think mostly for me, it's the stigma and the fact that there isn't a space currently carved out in the multidisciplinary team.
Right. Thank you, Lauren. Dr. Nandini, would you like to jump in here?
So I think it is both ways. It's from the patients and the doctors, and it's mainly the first and foremost, and especially in our country, is the the social concept, it's usually not discussed. Also, the concern that patients might feel that they may be judged by the healthcare professionals when they disclose things related to sexuality or intimacy. So you are not very sure how the person on the other side is going to respond. You don't know the. I mean, it depends on the social scenario. We are, as doctors, also human, so we have our own biases, and based on our own cultural perceptions, we may judge patients. So that is inherent. So that is one thing where patients don't feel free to share. Second is the psychological impact of an initial cancer diagnosis. Like, you're in that shock of dealing with the diagnosis of cancer, especially if it's like a stage 3 or a stage 4 disease. So to process that, okay, this is one aspect also that needs to be discussed. And even as physicians, we are also like worried about starting treatment early, getting biopsy, getting molecular in lung. So our priority is like getting the funds. So this, we kind of put it lower down on our list. And also the medical conditions of the patient. And I also feel a little bit of like in lung cancer, we tend to discuss these topics less because they don't directly involve reproductive organs or something that we directly associate with sexual needs of patients. So like maybe in a gynecological cancer, breast cancer, or testicular cancers, you would these conversations would be more higher up on the list. But in lung, you are like kind of, you think that maybe okay, that can wait for later. So that's a thing. And we also in our medical training are not really trained how, like at a basic undergraduate or post graduation levels, about how to deal with matters of like sexuality, asking sexual history without, like, and also like in a TMH OPD, when there are 30 people, you can't really talk about these topics because everybody is listening and everybody wants to listen to what the other patient is saying. So like these are the challenges we face in real life. And that's, I mean, sometimes you do want to have this conversation with the patient because you really want to tell them like you should not have get pregnant while on this therapy, or you should not breastfeed, or your wife should not become pregnant, you should use contraception. But then when you look around, you think like, should I broach this topic now, or maybe we put it for another time when there is more privacy? So these are the reasons why then this sexual health and intimacy gets pushed to the background.
Thank you. I think you've, covered all the aspects of why this conversation has not happened. Dr. Akhil, you also work at one of the busiest cancer centers in the country. And yeah, please.
Yeah. So actually, Nandini ma'am has summarized the entire topic in very great detail from both the perspective of a doctor and some perspective of a patient as well. And yes, we face a very difficult situation in terms of the sheer number of the patient which we have to see in the OPD, and we cannot for counsel. We do counsel the patients for some specific duration, but what is important, a patient has prepared a list of questions when patient comes to us, and I have written a editorial from perspective of a patient. Then and this has been this is under publication in NGM. The patient came with a list of around 10 points, but when the patient asks two questions to a doctor, the doctor was actually my resident sitting in front of me and discussing with the patient, and I was reviewing the other files with the patient. What happened when the patient asks two questions? First two question, the resident's answer was so confusing and so doubtful and somewhat discouraging for asking further questions. I saw that patient took back the previous list and did not ask third question onwards. So I knew that the patient has around 8 questions, which I could see from distance because I had got a peek on the list of the question. And then I asked the patient, what is the problem? And I saw there was a sexuality question also, which was there on the fourth or fifth point, but patient did not discuss it with my resident. So I got the clear answer. Yes, it is how you have built up the relation with the patient, how you have dealt with the patient previously, that helps the patient to decide and get confidence. Yes, I can discuss this point with my doctor. So it's an art. It takes time to have a relation with the patient and doctor. It's That is why AI can never replace a doctor and patient relationship, because we see every day, will AI replace doctors, will AI replace this, will AI replace that? That can never happen. We are humans, and we are dealing with humans as a patient and doctor, and that aspect can never be tackled by any non-human thing, however whatever the precision it has in terms of diagnosis, treatment, but the human touch, that remains the prime modality. And I may be providing same treatment as my one of the junior colleague or colleague, but some patients have developed already a bond either with me or that my colleague, and they will prefer to go to the same doctor again and again. So this is what about the bonding, and that bonding is very important so that the patient can actually discuss these intricate issues. So uh, you will think the patient had come to you to discuss on the first day. Patient will first discuss about cancer. On the first day, patient will not definitely discuss these points. We need to make the patient comfortable. We need to develop a bond. On the second or third, sometimes or later appointments, the patient will start to open up and discuss these points. And definitely, as a doctor, it is my preference always to try to develop a bond, which I learned from my teachers like Kumar sir and Nandi ma'am and Vanita ma'am, that how to build up a bond with the patient. So these are all important points which we gradually learn with time. And it is not only about the being a great clinician in terms of identifying the problems, clinical problems, and dealing with it. It is about emotional bonding, which helps us to understand. And yes, till the time this emotional bond is not there, patient will not be comfortable to discuss these points. So this emotional bonding, and today's world is uh, more becoming gradually more of professional relation between a patient doctor. That is why sometimes we feel that we are missing that bond in some of the patients. Sometimes patient comes up reading that from the Google, that itself deters us from forming a bond, because we know the patient will have already seen this, that, and then our information might not matter. So that discourages us from the point of view as a physician, that the patient has seen this. But we have tried to take it sportingly. And yes, I know, for example, today only I responded to a patient, yes, I know आपने ये देखा होगा, आपने ये पढ़ा होगा, इसके बाद ये भी लिखा होगा. Then patient became happy and became comfortable and tried to discuss further points. So all these things are there, and sexuality is very important issue. I think in our societal conditions, we tend to discuss it, but somewhat later it. But yes, as soon as that bond is formed, we should try to discuss it so that our patient can get the best possible treatment. And also, Lung Connect Foundation has helped some of the our patients to connect with us very deeply. They tend to listen to us multiple times in a month. First after visiting the OPD, then listening us in a Lung Connect Foundation meetings. Then themselves tend to develop a deeper bond with us. So all these ways help us. Thank you, Anand.
Thank you, Dr. Akhil. Before I summarize, Rachna ji, you've been through it as somebody with the lived experience of breast cancer.
Yeah.
What is your what are your views and your experience in this?
Yeah. See, during my journey, even during my treatment, because I got breast cancer at mid 50s, late 50s. And I was very positive because my doctors were very helpful. Let me be very honest. So for me, it was not the closed door most people are in. I met many people who would be just within their four walls at home or at the clinic, no outside contact because they were so scared. Females were very scared of, am I desirable? You know, am I still whole? Yeah, especially breast cancer, because it's part of the sexual this. So they thought, okay, yaar, ab to kuch nahi. There's nothing left. My partner may not want me anymore. So that fear was very palpable, and also there was this, that I think I should be grateful that I'm alive rather than think about sex and, my sexual health, etc. So that was what I came across, during my treatment.
Thank you, Rachna ji. Thank you for sharing your very personal experience. So what I, you know, take away from this is, number one, like Dr. Nandini said, even our doctors may have certain biases. They're not trained to have these conversations. Dr. Akhil said, rapport building is important. Lauren said, the taboo attached to it. Rasika said, the onus has to be on the clinician, which she's just 30 30 years old. And from her perspective, it is absolutely fair. And Rachna ji, it is, like Dr. Nandini said, there is a huge taboo attached to gynecological cancers. So, what you shared, I think a lot of women experience the same feelings. My next question, Dr. Nandini, is to you. When do you think these conversations should actually start? I mean, in an OPD like yours, at what point should these conversations start, and how should it actually look like?
So I think it depends on two things: on how well the patient is, like how acutely sick. I mean, if you're dealing with a cancer like a hematological malignancy or somewhere where there's an acute crisis, patient is on oxygen, obviously, these are the times where these conversations cannot happen. Neither the patient nor the family is accepting. So, I mean, that is one thing, how the patient's condition is at that time. And once the patient is medically stable and is able to like really have a conversation, it should start as early as possible. For generally, what happens is in cancers where, like if it's a reproductive organ or the breast, we inevitably do it in the first 2 or 3 meetings. But other cancers, it takes a backseat. So I would say in a stable patient as early as possible, especially when you're initiating a new treatment, then they need to know about, like in a young patient within reproductive age group, regarding what the effects of the treatment could have, or if it could have any teratogenic effects on later, like pregnancies, even in the future. Many times patients don't understand that, and suppose as an unplanned pregnancy, then they are like stuck as to what to do. So I think it should happen at least at the time of treatment initiation, if it's the first time you're starting some sort of therapy. But of course, in a patient who's not medically unstable, like hemodynamically, or like on those kind of situations, you probably would not want to add this, because the family or the patient is not at the time receptive, because of obviously they are struggling with something that is more life threatening than all these issues. So maybe in stable patients as early as possible, especially before planning some kind of chemo or radiotherapy or surgery, which has probably long term impact.
Right. So, would it be right to say, Dr. Nandini, that, in the initial assessment, for example, sometimes there's a list that's given to the patients, and
Yes, I think
yeah, so maybe, a statement could be added there so that it's also on their mind that they can ask this question from their doctor.
yes. I completely
Right.
agree. Usually in testicular cancers, patients who are, of course, like breast, ovary, where they need to decide if they're going to have an oophorectomy and all these happen by default. But in other cancers, I think we should have it in a kind of a checklist that these are the questions you could
Yes.
ask and how to go about it.
And I think that will also help, break the ice. So people would know that, this is something that can be done. Dr. Akhil, can I request you to jump in here? How can oncologists and nurses initiate conversations about sexual health? Because generally, it's not, the bias is not only one sided, or maybe the stigma, or the fear of having these conversations is not one sided. It is both sided, especially in the Indian context. So how can an oncologist and nurse initiate such conversations when they
Yeah,
see?
so basically, as it was being suggested, if there is a checklist or some point of that, we can discuss all the relevant points one by one, and just highlight that. If you have any questions related to this point, or what is your expectations from this point, that will definitely help us to open up. The patients might open up. We have seen that. We thought that this is a point. Similar points are not so important presently, but even when we hinted, the patient started a good amount of discussion, and that came up. So it is important to bring up the point. Then patient will definitely, the patients are some, most of the time caregivers, most of the time spouse, they are willing to have this discussion. Sometimes patient is not so comfortable, because patient himself or herself feels that this is a point which can be discussed later, or not very confident that can be discussed that point of time. The spouse helps them most of the time, and they bring about the discussion. So I think when the patient and spouse are there, this point can be discussed. For example, as Nandima was trying to highlight, in today only, when counseling a patient of breast cancer, I asked about the plans for further pregnancy. The patient opened up and told that yes, they have one child, but that they want future pregnancies, so they want as much of sexuality and ovarian functions to be preserved as much as possible, and that helped us to adapt treatment from the day one itself, from the day one of counseling. So sometimes it is very important, and this needs to come not only for the gynecological cancers and breast cancer, but this should come into action for many other cancers where we can plan the treatment accordingly.
Dr. Kill, do you think it's a good idea, especially in the Indian context, to get nurses involved in this?
So actually, nurses will be helpful in the busy setups, because most of the time it is thought that doctor will discuss about the drug, its toxicities, whom to contact, what should be eaten during this treatment. But these additional points are sometimes missed by the doctors themselves, or the patient themselves will tend to miss this point, because they think that, oh, doctor is seeing so many patients, I might not discuss this time, or doctor might get irritated with this discussion. So I think this is a good idea, that incorporation of nurses for discussion of these points will help. Actually, what we have done in our clinic, now, a lot of our patients are geriatric, while a lot of our patients are young. We have two bifurcations of patients. A lot of patients coming before age of 30, and a lot of patients coming after the age of 60. So what we have done, we have appointed a nurse already to take quality of life parameters for the patients, and that quality of life parameters has multiple questions on sexual health. So that helps us to break the ice actually. So the nurse is administering the questionnaire, at the same time the patient and the spouse are discussing the question and solving it, and they come up with, oh, this question is also useful, and it is going to be discussed, so they become much more confident also. So what we have learned with last few years, administering a simple quality of life, validated quality of life parameter like EOTCQL is important and helpful, because it helps us the patient to understand, yes, all these points are worth importance, worth useful, and they are constituting a quality of life parameter. So that has helped us actually, ma'am.
Oh, I think that's a great input and suggestion, and we need, I think, more hospitals to incorporate this, because once it's told to them, once it's actually verbalized, it makes the patient also comfortable, it makes the caregiver also comfortable, and it also puts the emphasis on the need to discuss this aspect of cancer care. So thank you, Dr. Akhil. Lauren, I'm going to jump to you now. Um, how can systems better support these conversations instead of sidelining it?
So I think, first of all, Campaigning for Cancer has done a lot of work on patient advisory boards. And I can tell you now, in each one of those patient advisory boards, sexual health and sexual and dealing with that comes up as almost a number one. And I think that there are a few things. We can start at looking at advocating on integrating a sexual health expert into the multidisciplinary team. We can also speak to the doctor on the onus of bringing the subject up. A lot of the time when patients are starting their journey, you don't know what you don't know. They don't know that this is going to become an issue. And I think that, Roscoe said earlier that it should be on the responsibility of the doctor. I think it's on the responsibility of a doctor to highlight that it might become an issue, and that, and to bring it up, to put it on the table, whether that conversation happens or not. And I think also that we as patient groups should create safe spaces for patients to share. I look at a situation that we had with, prostate cancer patients, where, everyone thinks men don't talk, but they do talk in the right environment. And it's creating those environments that we need to do. And, it was a patient, and he set up an online community. People don't have to share their videos, but they can get to listen to stories and then maybe ask questions. That's a good environment. So we need to understand, what does a safe environment look like for various patients and various times. Sometimes patients, it might not be the first thing on their mind, but someone in their in their family, it might be something. So we've also got to take a look at caregivers and explaining to caregivers how to deal with this and how to look at it. We all get told how we should, help patients with food and delivering and picking up children and all those kinds of things. But maybe there's a place for understanding, where that sits and how we can. And I think also, getting patients to speak about it. I don't think we speak about it enough. And when we do speak about it, people become uncomfortable. I recently saw where that same patient spoke to a group of urologists, and he said, I'm really sorry, doctor, but you didn't give me this information. It wasn't a good thing. I understand where you're coming from, that it's not something you've been taught and it's previously taboo and that, but I needed it. So he was telling the doctor he needed it. And I think we should listen to that and try and find those safe spaces for people to talk about this.
So I think, like you said, your organization has been doing a lot of advocacy in this. So the role of patient organizations and patient advocates plays a very, very important, it's a very important factor in this, because till we empower them, till we give them a safe space to talk about it, there's always going to be a stigma or a taboo attached to it. So as patient organizations, what are the additional things that we can do, Lauren? Can we create a toolkit? Can we, have somebody guide them through the process? What can be done in your opinion?
So I think, first of all, as patient organizations, we should be sharing resources that already exist. So if there's a really, really good international group that you could refer a patient to, why recreate the wheel? So we as patient organizations need to know what's out there as much before we start creating more stuff. And then referring people, and also helping doctors, referring doctors and saying, doctor, look, I found this. You might want to direct your patients to this kind of tool. I think also then as patient advocates, and I've said it a number of times, is that that this information gets included in all the education materials that we bring forward as that, and that even if it's a small section on the initial thing, that it's something that you might want to revisit. So you might not, as it was in the beginning, you're overwhelmed and everything, but this is something down the line you're going to have to revisit. So have a look. And I think also is finding out from your communities what that safe space looks like and feels like, and then creating those safe spaces.
Yeah. Thank you, Lauren. I think those are great inputs. And now I'm going to get the people who've been affected by this. Rasika, what would have helped you feel better supported, early in your care, with respect to sexuality, intimacy, reproductive issues, maybe even cryopreservation?
So Vandana ji, the first thing is that I'm representing a young voice here. I was diagnosed when I was 26 years old, unmarried, who was told that she needs to be taking chemotherapy for the next 3 months. Now, if you hear all these points, no doctor, at least in India, is going to even touch on the topic of sexuality with me. Because as soon as they tick the box unmarried, I think that's it, that's done there for a young patient. And I think this is a very big topic that needs to be talked, especially in countries like India, where you have to think if a patient who's diagnosed with cancer at a very young age might not even want to get married at all in their life. But that doesn't mean that they stop their sexual experiences. And I think this is also a question to Dr. Akhil and Dr. Nandini to think whether they would be comfortable talking to a person who is unmarried, but now they need to create this space to talk about sexuality. So I think this big burden of stigma that was there on my shoulder and also on the doctor's shoulder uh, did everything. And I don't think so we even started the conversation about sexuality or, let's say, fertility preservation or any sorts of things. It was just purely a conversation of medical aspects. So I think what would have really helped me is, as Lauren said, just to highlight or just to bring that point on the table that uh, this is something that might get affected, or this is something that you might want to discuss. And yes, we are there to discuss this. And I often compare my experience in India to my experience in UK now. When I started first my treatment in a hospital in UK, the doctors were new, everyone was new there. And yet the first question, as you mentioned, Vandanaji, there was like a checklist that they would ask, and they just very casually asked me whether I'm sexually active and whether I would want to discuss anything about that. And they're open to do that. That's it. I think that just created that space for me to even think whether I want to discuss something like that. And and that gave me the space to ask them whether there's something related to fertility that I need to look into, or uh, while being on treatment, whether I can be sexually active or not, and all those aspects. So I think just creating that space would have made a huge difference for me. Um, and I know this is a big ask for the doctors because, as I said, this is this huge stigma of for young patients who are unmarried and talking about sexual experiences. So yeah, I would really like to know Dr. Akhil and Dr. Nandini's thoughts on what could be done for young patients. But this is what I have to say.
And thank you, Rasika. Thank you for highlighting that. And you've spoken for all the young unmarried, men and women who get diagnosed with the early in their lives with cancer of any sort, and these personal biases can affect the patient-doctor relationship. The personal biases can also affect uh, the emotional health of the patient, because when you are younger, then you have a lot of dreams, you've got made a lot of plans, and suddenly everything is is uh, is uh, is disrupted. Your life is disrupted, and if the answers are not provided, it can make you feel unheard. Dr. Nandini, would you like to come in here?
So I agree with Rasika that sometimes these conversations don't happen and they should happen. But also there are some it also depends on the clinical context. Like for routinely for all testicular cancers would send somebody for semen cryopreservation, whereas fertility preservation in a woman is a little more complex because you need to stimulate the ovary with certain drugs to get the eggs at the right time point, and then you need them to be harvested. So it also depends in women. So that's a little, I mean, women have that disadvantage in a sense, like how long can we wait? In a male, you would do a semen analysis and in a few hours get to know if there are adequate sperms and should you undergo. So many of our testicular cancer patients do undergo this conversation unless they are really unstable or in the ICU. And both me and Akhil have like worked together in Euro, and we know that all our patients used to go, and there are a lot of affordable options now. It's not that expensive to cryopreserve semen anymore. With oocyte or preferably embryo cryopreservation is what a lot of the fertility experts recommend. But then in an unmarried person, you can't have the luxury of having an embryo cryopreservation because, I mean, you may not want an embryo cryopreservation at that point. So then you have to see how long you can wait, whether you're going to wait for those follicles to get stimulated. Then the patient will undergo general anesthesia, get the eggs retrieved. So that is a little bit of a challenge, but from a patient's perspective, even if I were to be a patient, I would definitely, I mean, cryopreservation or oocyte cryopreservation would be one of the questions I would ask if I had to have a cancer. So as a female in a reproductive age group, everybody has that right, but these are technical challenges. The second thing is what she said, and I also feel in our situation, in our society as women, there is a lot of bias. I mean, no matter how well educated you are, in our country, there is still no open conversation about women's health and sexuality as openly as in the West. And if anybody, I mean, it's not that it doesn't happen, but people don't want. I mean, there are like a lot of double standards. So these conversations don't come up both from the patient's point of view as well as the doctor's point of view. And if there's also, especially a relative, say for example, a young girl comes with the mother or father, so obviously you're not going to be able to elicit this history. In their presence, so like there are, it's a lot of complications, and as I feel as a doctor, I have also been through the learning curve of making myself comfortable how to get this history, like to be open to these conversations myself, which is okay when you're younger, because I mean you tend to adapt faster. But also how to be very sensitive on how to at the same time protect patient privacy. So if the patient doesn't want to disclose certain things to her family members, for example, so then you need to get this information without her privacy being violated, because in India, you know that I mean, you know how, the kind of environment that many women live in. We are probably more fortunate, but I have seen patients coming and telling me stories that I mean, which are sometimes quite disturbing, regarding how their spouses treat them, especially after a cancer diagnosis, with a relation to intimacy. And this is a very recent incident. One of our glioma survivors came, and she was so distraught. Sometimes, like Lauren spoke about safe spaces, I feel that for many women, the clinic is a safe space. Maybe the home is not a safe space, and none of them, especially in our Indian setting, can like express these things to their family members, because of the kind of society we live in, especially underprivileged women or women of who do not have access to certain things, lack of education. So then this young lady, maybe in her late 30s, would keep on coming and telling me about her husband and how he's doesn't understand, and a lot of intimacy issues. And she was like educated up to 12th standard, so she was very vocal and very she always, throughout her treatment, very eloquent. She would point out all symptoms. So she every time would come out distraught and then sit in the neuro OPD and talk for 1 hour. And then finally, I had to send her to the psychologist to get counseled. And I told her, get your husband along. I will talk to him. But then I realized, I mean, she's at such a disadvantage. She's like, I'm just fed up. I don't want to see him anymore. So then what do you do? Like, you can't really solve the social problems that they live with. So it's very complex. I think, of course, the onus is on us. We should initiate. But sometimes with all these complicated things, it becomes very difficult for all the points to be addressed. So I feel strongly that there should be a nurse, like Akhil said, and there should be probably a psychologist also in our routine setup, who can handle these problems, because sometimes we don't have the time in our setting to give attention, and it has to be done in a sensitive manner, especially if the patient is a young woman. There are a lot of things that you have to keep in mind, considering the social milieu, the job, or whatever their scenario is.
Thanks, Dr. Nandini. Dr. Akhil, would you like to come in? Because this is a
Yeah.
question that Rasika specifically asked the doctors. So
Yeah. So actually, one solution which we have developed to tackle this solution is that for all young patients below age of 30 years, we send genetic testing now. We have a dedicated genetic clinic with four genetic counselors, a psychologist, a social worker separately. And we do our genetic counselor team, which is composed primarily of girls, young girls, who are the genetic counselors, is helping us a lot. That has actually helped us in the last few months. We are seeing that patients um, um, being able to discuss these points, and then the genetic counselors come back to us that yes, there was such a conversation, and they have expressed this point, which they could not discuss with me or my colleague or my residents, and the point comes up to me, then I can discuss about the further steps and next steps. So that has actually helped us. So be it a single nurse, be it a part of your team members who are able to discuss such aspect. So this is one of the solution. Actually, it's as Nindi ma'am highlighted, it is not so simple for us as well. So it is actually very complicated. So it's not most of the time. It's like your status, single, married, or it's complicated. It's actually complicated to discuss, and for patients' perspective also, it's not easy actually. So. Um, and definitely a team is required to help and sort out these problems. And as Nandi ma'am highlighted, most of the time the patients, young patients, will come with their family, close family members. Even if they are married, unmarried, they will come with a spouse. It is much easier actually for us actually to discuss. When the patient is unmarried, it becomes really difficult, and initiating the conversation is also difficult for us. That how the parents will react to this, how we can discuss this in a more discreet way. So that is where the genetics clinic has helped us actually, and we do tend to get a genetic testing for a large number of patients. Even if they are not tested, they get counseled for all these points. So that has actually helped us. This is one of the solution which we have devised in our resource constrained settings of huge number of patients, but that has actually helped us.
Yeah, Rasika, I know they're not the a great initiative by Dr. Akhil, she says, and I think this is one of the way forward to address the concerns of the younger patients. Rachna ji, as somebody who was diagnosed in her mid-50s, do you feel that you could have been better supported in this area?
Not me, not just me. I think even my husband, because it's not just our fears, it's theirs also. Because I had breast cancer, thankfully it was there was no mastectomy or something. But maybe he also didn't know how to approach me. It's not always about sex. It's about feeling, that tenderness that they need to show. Even that touch is good enough. My body has changed. So, I have that fear that I don't know how I'm going to look, in front of him, or how is he going to feel about me. But it may be that he also may, not ask me some questions because he may think he'll touch some raw nerve. So I think his counseling, the couple counseling is very important. Like the doctor is saying that, at least it's easier with the spouse. But in my case, maybe they thought in India, mid-50s, late-50s, it's not necessary. But it's not always so,
Yeah, yeah. Thank you, Rachnaji. I think this is also a very, very important thing. While Rasika is highlighting the concerns of the the younger people, you're highlighting how it is at a certain age, say above 50. And this attitude I've seen also when the doctors have actually told the patients, "Okay, but you're above 50, it really doesn't matter." And also, it is
or
so
be thankful you're alive, just
absolutely. And then these, getting over the personal biases is very important. And
well,
caregiver equally needs support. So thank you, Rachna ji, for highlighting this. And I think what Lauren said, it is so important to have an MDT, a multidisciplinary team to handle issues like sexuality and intimacy. So. And now my next question is to Dr. Nandini. I think now we're going to get down to the basics of it. Dr. Nandini, when we think of sexuality, what are the key treatment-related impacts patients should be prepared for? Because they're not told. There are chemotherapy-related side effects, there are radio, side effects, targeted therapy side effects, but they're never told. They're never given a list of what to expect. When the treatment starts, how is it going to affect their sexuality? So what should a patient expect, irrespective of the type of cancer?
So it depends largely also on what type of cancer and what treatment you receive. For example, like suppose you have a gynecological cancer like cervical cancer and patients receive chemoradiation. So there the impact would be more direct because again, when you have radiation, there can be vaginal stenosis. There's also a lot of inflammation leads to diarrhea and other issues. So that makes a difference. Suppose there's a mastectomy. So post mastectomy, the skin basically patients because of the cutaneous nerves getting cut, they have like altered perception on the skin. So it depends on what kind of treatment you undergo largely. So if it is for chemo, like chemotherapy can cause chemo-induced menorrhea and also can affect the fertility, and depends on what type of chemotherapy. Not all, like certain drugs like alkylators, platinums, they have a high incidence of causing infertility by damaging basically the sperms where, I mean, the testis where the sperms are produced, or the ovarian fat follicles. There are different strategies people use to preserve. So for males it's quite easy, you can semen cryopreserve. For women you either do a oocyte preservation, some people give GnRH and analog. So there are a lot of data on how to do fertility cryopreservation, especially if they are younger, like young adults, adolescents, even sometimes children also they consider a transplant. Like if patients are undergoing I'm not bone marrow transplant, stem cell transplant, those use high dose chemotherapies, which are all alkylators. And these people, especially if you have a lymphoma, you expect they are probably going to do well after transplant. They're mostly going to become infertile. So again, you need to see what drugs they are receiving and the impact of that on the fertility. Then about the impact of drugs on like libido, sexuality. Like if you have anything that is suppressing your hormones, like for example, a prostate cancer patient is getting a GnRH antagonist or an agonist, which is suppressing the pituitary and the testicular axis, and your testosterone levels are suppressed. So it's like you're inducing a menopausal state in a man. So everything that a postmenopausal female can experience, right from the psychology, it's well documented, a lot of studies and a lot of things, right from cardiovascular risk about cholesterol going high, increasing your list, osteoporosis, everything that happens in a postmenopausal woman can happen in a male, including mood changes, depression, anxiety is much higher. So these things, you're like kind of introducing a situation where the hormone is completely deprived. So that happens. Similarly, in women who have breast cancer, if they're on like, of course, if they're postmenopausal, they're on, say, aromatase inhibitors like letrozole, lot of body aches, bone pains. These are pretty common in those patients, and they sometimes are so bothered by it, then you change it to tamoxifen. So drugs, individual drugs have particular side effects. So depending on what you're starting the patient, you should tell them the possible side effects on the sexual health, reproductive health, long-term fertility, and teratogenic potential. Like certain drugs, if you do have a pregnancy while on treatment on a short interval, you could have genetic malformations in the fetus. So you need to counsel it, and you should actually tailor it to what the patient is receiving, so that they know what they are receiving rather than just a blanket kind of a statement.
Thank you. I think it's very important for the patients to be aware of how it's going to affect them overall, not only in terms of, physically. So it's sexuality is also affected by the treatment. My question is now to Lauren. We've spoken about men and women. When we talk of a cancer care has to be inclusive. So how do we ensure sexual health care is inclusive of the LGBTQIA plus community as well, and diverse relationships? Because though we're having conversations about sexuality of a man and woman, till now I really haven't heard of the this emphasis being given to the care for the LGBTQIA plus. Yeah, Lauren, this is
Sorry, I was just trying to unmute.
Okay.
Yeah, no, I was just trying to unmute. Apologies. So for me, that's a difficult question, and I don't think I'm very equipped to do it. And the reason why is because there's not a lot of focus on this. It's not something that we have explored in depthly, and it's such a complex medical terms and that we see that those patients are going through, often if they're on treatment for gender reassignment or that. So something like that definitely has to be included. But I have to tell you that as groups, as patient groups, I don't think we're focusing on that. Does that mean it's right? Absolutely not. If we truly believe that every patient is due access to treatment and access to the supportive care they need.
Lauren, I've lost you there. I can't hear you. Lauren?
Looking at, and maybe as groups we can reach out to those communities to find out what work's being done and how can we translate some of that work into the cancer patient's journey.
Right. Thank you, Lauren. And this is a big unmet need when in each area of cancer care, not only when we talk of sexuality and intimacy. And we need to focus on this very special group of people because cancer care needs to be inclusive. So a lot of work has to go into this. I'm at the last 5-7 minutes of this webinar, and I'm going to do a quick busting of myth and facts. I think this is very, very important, and it'll be good to have everybody on the screen, because I'm going to shoot out statements, and I'm going to ask each one of you to tell us whether it's a myth or a fact. You can say yes or no if that's easier. So let me start with, I think there are so many myths about sexuality, and I'm really convinced that internet wants to confuse us more, and it just keeps making newer ones every time. So let's together bust this myths. Um, Dr. Nandini, sex is off limits during treatment.
Uh, Depends on what kind of treatment you're receiving. It also depends on, like, suppose, for example, you're receiving radiation to a part of the pelvis where there's a gynecological tumor. There, the mucosa and the skin is affected. It becomes more, like, it becomes more fragile. So you can probably get like an injury during that time. So I think those kind of scenarios you have to be careful. Also, acutely sick patients, neutropenic patients, in these, the risk of getting like infections may be increased, but that's like, I mean, it's variable. People who are on therapies which do not cause any major like suppression of immunity or major loss of function, non-gynecological cancers, patients who have like been completed adjuvant therapy, are on maintenance hormone therapy, I don't think then there it's off limits. That's fine. They just need to be counseled basically about the risk of pregnancy, if they need to take any precautions. So if the drug can be harmful to the fetus, so they need to take contraception and contraceptive precautions, that needs to be explained to them. So many drugs like our oral TKIs, immune checkpoint inhibitors, and all, they don't, I mean, they don't make you sick or unfit. So in that sense, it's not off limits. You just have to tell the patients that maybe a pregnancy on XYZ drug is not advisable. It's not safety for the fetus, is not, no, you're breastfeeding, we don't know the safety because it's excluded in breast milk. These things have to be told. It's not a blanket off limit.
Right, right. So my next statement is, if my libido took a vacation, it means something is wrong with me. Rasika, how have you felt about this?
Well, definitely a myth, because, of course, as Dr. Nandini said, there can be effects of the drug and it might affect you for some time, but I don't think so. That's all for you. So, yeah, definitely a myth.
Yeah, so it's not basically a failure, it's the biology and the stress associated with everything. So the next one is, okay, this is again for Dr. Nandini. You can catch cancer from somebody during the sexual act, like a flu.
You
This is a
cannot
very,
catch
very...
so you cannot catch cancer, but you can catch viruses which can lead to cancer. So that you have to be aware of. Human papilloma virus, the most common transmitted sexually transmitted virus, which is the cause of the most common cancer. Now, the second most common cancer of women in our country, that's cervical cancer, is a sexually transmitted virus, and that leads to cancer. So that is one thing you have to keep in mind. You won't get cancer directly, but you will get a virus which will lead you to get cancer. Now there is vaccination coming up, of course, screening with pap smears. So it can decrease the risk, but you have to be aware. Hepatitis B and C, both can be sexually transmitted, increase your risk of getting hepatocellular carcinoma very high. HIV itself doesn't cause you to get cancer, but if your immune system is suppressed, you can get cancers in a HIV state. So these are all sexually transmitted viruses. So you have to be aware of viruses that can predispose you to getting cancer, but directly you may not get cancer. Like, for example, if your spouse has non-small cell lung cancer and is treated, you're not going to catch the non-small cell lung cancer from your spouse, but you have to be aware of these viruses that can get transmitted and increase your cancer risk.
Yeah, I think this is very, very important, because this is a question that keeps coming up very often. That my husband, for example, in lung cancer, like you said, if my husband has lung cancer, will I get it from him? So this becomes a huge barrier in having intimacy with your partner. So thank you for answering that. My next question is again to you, Dr. Nandini. Pain, dryness, erectile dysfunction are my new destiny.
So
And
all
why?
are manageable. Of course, they don't. So it depends on what treatment you're receiving. Sometimes these effects may be permanent, sometimes they may be temporary. But of course, for erectile dysfunction, there are a lot of options available. People do get it. Sometimes, other than erectile dysfunction, they get retrograde ejaculation. So we have young males who have had testicular cancer and a retroperitoneal lymph node dissection. So the autonomic nerve fibers can probably get involved depending on how bulky the nodes are, and this is what they compile. So a lot of urologists do evaluate and manage these conditions, so they just need to seek help. For women, it's basically lack of hormones. So then there is also local vaginal estrogens and other things that you can get after you contact a gynecologist to help with these issues, because these are known side effects of our therapies. You'll have to individualize. It may not be same symptoms for all people. It varies depending on what kind of treatment and what part of the body is involved with the cancer. So that is little different. So there are treatments for these. Of course, it is inconvenient. Sometimes you may have a permanent issue, like if you're postmenopausal and you're taking something that again suppresses your estrogen levels, you are definitely going to have vaginal dryness. But then local creams and other therapies are
Yes.
there to kind of mitigate it. It may not go off completely, but it can reduce.
Yes, and at this point, I think I'm just going to just add that if you are experiencing any symptom like this, please reach out to your doctor who can advise lubricants, local creams, and you can reach out to a sex therapist who can tell you and have communication, can encourage a healthy communication with your partner, and you can still have a healthy sex life. This is next one is as a therapist, I'm going to jump in and bust this myth. Self-pleasure does not count. It absolutely counts. You're literally the expert on knowing what feels good for you. Solo sexual activities support sexual health, confidence, and stress relief. So do not feel that self-pleasure is a taboo and you should not be doing it. My next myth is to Lauren. Talking to a doctor about sex will be awkward, so I shouldn't talk about sex at all to the doctor.
Depends on the doctor. And one of the things, and one of the things I always say is your oncologist and your treatment team, you're going to walk a long road with them. So you need to be comfortable with them from the beginning to have those kinds of conversations. Look for doctors who you can be comfortable with to have those conversations.
Right. And maybe we need to print out pamphlets for the doctors as well. My next question, Rachna ji, not question, next statement is to you. There's nothing that can help with the sexual side effects.
No, of course, there are so many therapies now, medications, they can help. It's a myth. It's a total myth.
Thank you. Rasika, cancer killed my confidence, so intimacy is over at 29 if you were to think like that.
I mean, yeah, again, of course, a myth, because here I am trying to advocate and tell everyone that cancer is not a death sentence and your life does not change absolutely because you've had cancer. So, in a general way, nothing will change forever. Things might change for a brief period of time. But yeah, nothing is a final sentence. So, yeah, definitely a myth.
Yeah. So I'm just going to end with, what this sentence, that intimacy after cancer isn't going back to what you were. It's maybe about moving forward in a new way with a new normal. And that can help change the perspective. Before I close, to each one of you, I have one last question. What is one actionable step each person can take to support sexual well-being of those who've had a cancer diagnosis? Lauren.
I think everyone needs to be brave. From the patient to the patient groups to the doctors. This is not an easy topic to discuss, and I don't think it's an easy topic to discuss anywhere in the world. So we need a little bit of bravery.
Dr. Nandini. You're on mute, Dr. Nandini. You're on mute.
So I think for me, I wish I had time to have this discussion with every patient. I mean, it's always at the back of my mind, but unfortunately, isn't enough time. So the patients who do come over a long period of time, you do get the opportunity to do this. But I think communication is the first step, and I think we need to probably. I know it's not practical in the scenario where I work, but we need to probably allocate some time. Like we do have support groups, and when we have support group meetings, and you realize patients bring up all these issues, and this is probably what was in their mind all along and we never addressed it. So I think communicate and give time for patients to discuss about intimacy, sexual health and reproductive issues and everything that we don't generally do it in our OPDs.
Rachna ji.
I think saying out loud your fears is the first step towards healing. Should start a shame-free conversation.
Most importantly, Rasika.
I have a message for all the young people out there that let the society bear the stigma, but not you. Uh, it, I mean, yeah, I think I just
Lovely.
end there. I think that says it all.
I think that gave me goosebumps also, Rasika. So thank you for saying that aloud, because the younger people need to be confident in their own skin and not be worried about what's happening to them, to the society around them. So thank you, each one of you, for being here today and adding so much, substance and knowledge to this wonderful session. Sexuality remains a meaningful part of life, identity, and connections before, during, and after cancer. Before I close this session, I'm just going to मैं जो हमारी हिंदी बोलने वाले ऑडियंस हैं, हमारे हिंदी समझने वाले जो लोग हैं, उनके लिए मैं एक थोड़ा सा इसको समराइज करना चाहती हूँ आज के सेशन को। कैंसर देखभाल में यौनिकता को शामिल करना इसलिए आवश्यक है क्योंकि कैंसर और उसका उपचार न केवल शरीर पर बल्कि व्यक्ति की आत्म छवि, भावनात्मक जुड़ाव और अंतरंग संबंधों पर भी गहरा प्रभाव डालता है। कई मरीजों को दर्द, थकान, हार्मोनल बदलाव, शरीर में हुए परिवर्तन और मानसिक तनाव के कारण यौन जीवन में कठिनाइयों का सामना करना पड़ता है। परंतु इस विषय पे बात करना अक्सर शर्म या असहजता के कारण टाल दिया जाता है। जब स्वास्थ्य सेवाओं में यौनिकता को खुलकर चर्चा का हिस्सा बनाया जाता है, तो मरीज और उनके साथी अपनी चिंताओं को खुले दिल से व्यक्त कर सकते हैं, उचित जानकारी और उपचार प्राप्त कर सकते हैं और जीवन की गुणवत्ता को बेहतर बना सकते हैं। इस तरह यौन स्वास्थ्य पर ध्यान देना कैंसर उपचार को अधिक मानवीय, संपूर्ण और सहायक बनाता है। तो आपका अगर कोई भी प्रश्न हो इस यौनिकता को लेके, आप हम सबको रीच आउट कर सकते हैं। सो a huge thank you to everyone who's been present here today. And I hope the audience leave with knowledge, tools, and the reminder that everyone diagnosed with cancer deserves support in every aspect of their well-being. On behalf of Lung Connect, thank you, everyone. Be well, take care, and